So I'd like to share with you some of what we do in the United States with retinoblastoma. I have no financial interest or relationships to disclose. I'd like to talk about chemotherapy for retinoblastoma, the victories and the defeats. I practice on the oncology service at Roadside Hospital in Philadelphia. So it's all about kids and life and vision. We manage retinoblastoma with enucleation, intravenous chemotherapy, intraarterial chemotherapy, vitreous and aqueous chemotherapy, and plaque radiotherapy. But mostly what we do is intravenous or intraarterial chemotherapy. When do we enucleate? Well, if it's a large mass with no hope or a potentially high-risk eye, or the parents seem to be unreliable, or where chemotherapy is not available, we will enucleate. So there are some factors that prompt us to enucleate. We use intravenous chemotherapy mostly for bilateral retinoblastoma to treat both eyes at the same time, low risk. We use intraarterial chemotherapy generally to treat unilateral retinoblastoma, and intravitreal and intraaqueous chemotherapy when there is vitreous or aqueous seeds, and plaque radiotherapy when it's a very localized lesion or where we're not getting a good chemotherapy response. Now, in order to understand retinoblastoma, it's important to know the international classification of retinoblastoma. We published this report several years ago in Current Opinion in Ophthalmology on a basic understanding of the current classification. Back in the day when I started, we were all using Rees-Elsworth classification, and nobody could list the classification verbally because it was too confusing. But this classification is much simpler. This was designed in 2004 by a team who worked together in Paris. We have groups A, B, C, D, E. Group A is small. You can remember A by the letters, small, S-M-A-L-L. 3 millimeters or less in diameter. Group B is bigger than 3 millimeters, or tumor in the macula or with subretinal fluid. Group C have localized or contained seeds, very close to the tumor. Some say within 3 millimeters of the tumor. Group D has more diffuse seeds, greater than 3 millimeters from the tumor. I like to put numbers on this because I think it keeps us all honest if we describe based on numbers. And then Group E is extensive disease, where it's filling more than 50% of the globe, where there's neovascularization or immediate opacification from hemorrhage. So here's how we give the chemotherapy. Intravenous chemotherapy is given into a vein. In Philadelphia, we don't use a port, and we use 3 agents, vincristine, etoposide, carboplatin. On the other hand, intraarterial chemotherapy is given into an artery, usually the femoral artery, but we also use the radial artery in older patients. And the reason we catheterize the femoral artery is it's easy access in a chubby child. Intravitreous chemotherapy is when we inject into the eye for vitreous seeding using either melphalan or topotecan. Chemotherapy success depends upon the stage of the group. Here we see the yellow columns indicating success with intravenous chemotherapy. So we have really good success with A, B, and C. And we've actually followed these patients now for 20 years. And what the success you have at 2 years is generally what you're going to have at 20 years. We didn't know this until we just collected our data, and we'll be publishing this soon. Group D has intermediate success, about 50% success, with intravenous chemotherapy, and Group E even less. Now the blue columns indicate results from intraarterial chemotherapy. Of course, we don't use it for Group A disease, but we use it for B, C, D, and E. And you can see B, C, and D all have a high rate of success. 94% or better have the globe saved and avoid external beam radiation. Whereas only 36% of Group E are successfully treated, but we can really boost this. So intravenous or intraarterial is good for A, B, and C. We favor intraarterial for Group D and E, and we can boost the success with Group E retinoblastoma by adding in intravitreal chemotherapy. Now, what is tumor control, subretinal seed control, and vitreous seed control, depending upon intravenous or intraarterial chemotherapy? In a big study that we did, we found that solid tumors controlled in about 60%, subretinal seeds in less, in about 30% of those treated with intravenous. But it increases once you add intraarterial chemotherapy. So, across the board, bit more powerful, but maybe a bit more dangerous than intravenous chemotherapy. And all of these differences were significant. So for unilateral retinoblastoma, intraarterial chemotherapy wins, at least in the US, at least in Philadelphia. We prefer to use IAC because we get better control and the child has less exposure to chemotherapy. This is why we choose IAC for unilateral retinoblastoma. And this is important because most unilateral retinoblastoma, at least in the US, comes in as group D or E in about 75% of cases. Now for bilateral retinoblastoma, we prefer not to go up and catheterize both carotid arteries. We prefer to use intravenous chemotherapy. We think IAC could be a bit risky, especially with some of the vascular occlusive risks, and it's not likely to control other conditions related to germline mutation, such as pinealoblastoma or second cancers. So this is why we choose intravenous chemotherapy for bilateral retinoblastoma, at least in Philadelphia. Not everyone agrees with this. So let's look at a few cases. Here we see unilateral retinoblastoma, exophytic group D, subretinal fluid nasally. We give 1 dose, 2 doses of intraarterial chemotherapy, and you can see how this tumor shrunk down beautifully. Flat retina, a little bit of modeling of the RPE, but this child has the eye saved and maybe with some vision. On the other hand, this child comes in with bilateral retinoblastoma, and you heard me say we prefer intravenous chemotherapy for bilateral disease. We give the intravenous chemotherapy, the tumors shrink down, but it's really an art. This requires more of an art of treatment, detecting small recurrences, because you're going to see perhaps more recurrences with intravenous chemotherapy. And right there, you can see there's a little subtle seed, hardly shows. You have to check photographs month to month in these cases. And that's one that we would treat with TTT because we were concerned that might represent recurrence. Here's another unilateral retinoblastoma. Leukocoria is visible. This is group D retinoblastoma. The tumor seems to be mostly nasal. And here's where I get an ultrasound. Because if the tumor is nasal and I can see my optic nerve, I presume when it shrinks down, I might have a macula. Let's see what happens. That's the tumor. Here's the RetCam image. We have a little bit of normal retina supratemporally, and once we give the IAC, we've got a macula. This kid wound up with 20/40 vision, macula intact. I'm glad we did not enucleate that eye, but this took a little more than 2 cycles. It took 3 doses of IAC and 6 doses of intravitreal melphalan to achieve this control. You can see on the OCT, in the affected right eye, OCT actually looks quite good. Photoreceptors look pretty good. RPE's a little bit mottled, but still, we've got the eye and we have some vision. Now, in the Indian Journal of Ophthalmology, Feroz Manjan wrote a really nice analysis of intraarterial chemotherapy worldwide. And she goes through all the different agents that are used and how we get to the eye with the different pathways to the eye. And she titled this a paradigm change, and I really have to underscore that. Intraarterial chemotherapy has really changed how we handle retinoblastoma. She goes through some of the terminologies: primary versus secondary IAC, tandem versus bridge IAC, rescue IAC. These are all terms we use when we employ intraarterial chemotherapy. Just like to touch upon some special interest or special considerations with IAC. Minimal exposure. We always tell every patient your child's going to get 3 cycles of IAC, but not everyone gets 3 cycles of IAC. Here's 2 cases where only 2 cycles were given. Before, wonderful response, so we gave a 2nd dose and we stopped, and the child did not need anymore. And here's another, macular RB, got a good result after 1, gave a 2nd one just to be safe, and we stopped after 2 doses. So there are special situations where you can get by with 2 doses. I always hesitate to do short of protocol because I worry about recurrences. How about the youngest and oldest? You can't treat a newborn with IAC. These kids have to be big enough for a catheter to go through their carotid up to the ophthalmic artery. Generally, our youngest patients are 3 months old. You can't send anyone before 3 months of age to get IAC. We will, quote, bridge them with systemic chemotherapy until they grow up a little bit. Then we can finish off the tumor with IAC. But we have done IAC in this big 2-month-old. He was a big young boy, and he had this macular retinoblastoma. He got 2 doses of melphalan IAC, tumor responded, and that was maybe 10 years ago with complete control. So what's the oldest that we've treated with IAC? The oldest was a 32-year-old man. He was seen in Texas. They had given him treatments in Texas. He presented at an older age, and the tumor was coming back. So we went in and we did IAC in this older patient, shrunk the tumor down, and he did well. Here's a 13-year-old girl who had unilateral retinoblastoma, extensive retinoblastoma. We used the transradial access. Remember I said we go either by the femoral artery, but if you're old enough, like over 6 years of age, we can go by the radial artery. Why is this important? Less complications. Because if you go by the femoral access, you could get retroperitoneal hemorrhage. And here's IAC rescue in a patient who had chemo reduction elsewhere, where we can see recurrence of tumors. IAC can be used as a primary or a secondary treatment, and you can see it cleaned up this young child who was sent up to see us from Duke in North Carolina for treatment. So what is the real risk of complications? We always worry when we do IAC that we're going to get ischemia to the retina. And have the events of ischemia lessened in recent years? Well, Dalvin et al. Looked at our data and divided, and this was published in Ophthalmology 2018, comparing the early years when we just started IAC to the recent years. So she compared 2009 to 2011 versus 2012 to 2017. And basically what she found was the classification and all the clinical features were the same in those 2 eras. So there wasn't any difference in the extent of the disease, but the complications differ. If you look at the early years versus the recent years, ophthalmic artery spasm decreased to 0% in recent years. In fact, in recent years, we hardly see any retinal complications with IAC, and that's a tribute to a good catheterization by someone who's very educated in how to do this. Not going into the ophthalmic artery, but just facing the ophthalmic artery so we don't get occlusion. Injecting the vitreous is a very profoundly important technique to save eyes. We use a 32-gauge needle. We go through the pars plana. As we're removing the needle, we apply cryotherapy to the site, rinse off the cornea so we don't get melphalan toxicity to the cornea, jiggle the eye so that we get dispersion. And you can see in this dark photo there are vitreous seeds here, and this is before and after treatment, and this is big vitreous seeds before and after treatment, showing that vitreous chemotherapy is effective. Here's a child who came from a long way. This was her remaining eye. She had extensive vitreous seeding, and following intravitreal chemotherapy, it cleared up nicely, and the macula was revealed. So both we and Jasmine Francis have looked at the risk of injecting eyes with vitreous chemotherapy, and we basically came to the same conclusion. There were no extraocular tumor events, no extraocular seeding of retinoblastoma in our series and in the collaborative effort that Jasmine published. Sometimes we even do what's called precision intravitreal chemotherapy, where we actually take the eye and we just inject right over the seed of concern. And here you can see a seed sitting on the retina. We inject right there where it is because we don't want to get dispersed toxicity from the melphalan. And you can see below that seed went completely away. And here again, a recurrence of a vitreous seed right over the apex of a regressed tumor. We inject right on the seed. We don't jiggle the eyes in these cases, and we get good regression with very little toxicity. So, in conclusion, then and now, you be the judge. Mother was treated with radiotherapy 35 years ago in North Carolina. Baby comes to see us and gets chemotherapy and has both eyes saved and has vision and has no dysmorphism and has her life ahead of her. We published this in JAMA Ophthalmology, just to show how much progress we have made with retinoblastoma. So looking back, we've made great progress. We use all different types of chemotherapy, whether vein, artery, vitreous, or aqueous.